Hey guys, we're going to try some video lecture things. Brand new to this, I just downloaded this program. We'll see how it works. If you guys like these, I'll keep doing them. If they're not going to get done what we want, then we'll just do something else. But I figured to give this a try. The Google Plus page is okay. A lot of you guys aren't really, you know, keen on putting your stuff out there, and I totally understand. Um, If you want to talk to me about any of your cases, any problems, always get a hold of me. And I think all of you know that. Um, I'm here to help you guys out. I'm a huge fan of the new system. I'm trying to get this system to go this way for a long time. So I'm going to be a big supporter. Get a chance to run with you guys once in a while, which is awesome. Um, my new world is quite different, but it gives me opportunity to do things like this, and um, we do a lot of training, lots of education. We get lots of feedback, and we have people who are on top of things. We do a lot of reading, and um, most importantly, we get to take what we're reading and put it into practice. So I figured um, we'll try to get through some of these protocols. Maybe it's a good starting point. You guys just finished ACLS, so cardiac protocols might be a good place. So we'll get right to it and see how this goes. Chest pain, acute coronary syndrome. Not all chest pain is STEMI. Cardiac injury, we talk about the patterns, and we talk about, how the heart acts, and it gives off enzymes, and it gives off changes that we can record in our 12 lead EKGs. We're starting to do 12 lead EKGs, which is fantastic. You guys are doing them more and more, and you're getting really good at them. The placement of the 12 lead, of course, is the most important. It doesn't matter who puts them on as long as they're on in the right places. A little pearl to remember about right-sided 12 lead. You put it on exactly the same way as your left side, or normal, and you just take VR, or excuse me, V4, and move it to the right-sided V4R placement. Exactly the same as on the left, it's just on the right. You don't have to move any of the other leads and then reshoot the 12 lead. And always remember on the 12 lead paper to write on there that it's a right side V4 look. That gives us a really straight look at the right ventricle, so we can rule out right-sided MI. It's really important. Uh, right-sided versus left-sided, they present the same. They have the same type of chest pain. They could even have jaw pain and left arm radiation pain, and it could be that right wall. So, your what you're looking at, how they're presenting, could be exactly the same. And we know that the right side of the heart is our preload dependent side. Nitro works on afterload, but it's affecting preload, because if we're letting the blood go out of the heart easier, and it's getting rid of more, then we have less coming in on the other side. Nitro vasodilates coronaries, and it vasodilates some of the larger veins and arteries around the heart. Okay, so nitroglycerin works really great in CHF because it dilates the arteries going to the lungs, and it will create room for that fluid to shunt off. So CHF is really big with nitro use. Um, so our right-sided, we give them some nitro, you might drop pressure. Now you got to catch up with fluids, and um, the longer the heart is hypoperfusing, the more damage is happening. Think of your heart just like your brain. Your heart needs to be perfused. It needs a good blood pressure. And if you take that blood pressure away, um, the more damage can occur. So you have to be pretty careful. Sometimes we don't think of it that way. We just like, well, they're hypotensive, so give them a little food. They're having pain, so we want to give them something for that. So what we're looking for in these new 12-lead things, of course, is STEMI. Okay, so we're looking at the EST segments. Um, this lecture, I won't go through all the views and all that. I just want to get through this protocol. But from the 12-lead, we can figure out, what arteries are involved, and then we can kind of go off our treatment from there. So to get excuse me, to get going with this, oxygen. Okay, oxygen is important as the heart is struggling. It's burning up lots of oxygen. Your heart burns 65% of your oxygen. That's floating around in your blood, so it burns up a bit. So we want to be careful because too much oxygen is not good for you either. So they give you the 94 number here, which is great, at or above 94. Anything below 92, you're not quite getting enough. So you kind of have to remember, 98, 99, you don't really need that much, and it's actually long-term bad for you. So trying to get it in that mid-90 range. One thing on oxygen saturation, of course, is lag and your probes and things, but you have to remember with oxygen that if you're dropping the sat, it doesn't always mean you need a higher concentration of oxygen. The oxygen might be plenty, it's just not getting um, into the blood. So if your sats are dropping, your respiratory effort is failing. Always put those two together. If the sats are dropping, don't just don't just crank up the oxygen. Figure out what's happening. They might be, going into respiratory failure, or it might even be like a VQ problem where, maybe they have a clot in their, blood or in their lung, and it's turned into a PE situation, or, something is stopping the oxygen from perfusing across the membrane. So those people need ventilation. If the respiratory drive is okay and they need positive pressure, you just put them on CPAP. Okay. Aspirin is awesome. It's pretty much the only thing we give in chest pain that does a damn. To be honest with you, it's going to coat the platelets, make them, not stick so much. Remember, platelets as they flow through the coronary arteries, um, as the heart starts building thrombuses, um, those thrombuses become active and they activate the platelets. So the platelets start sticking to each other and making the thrombuses bigger, and and that stops your blood flow. So aspirin deactivates that mechanism in the platelets, so they don't stick as much as they would. We're given 324, and that's chewable. I think it's very important for our patients to chew the aspirin. We're getting more of the dose into the bloodstream. If they just swallow them without chewing them, a lot of that aspirin dose is getting, through the belly into the liver. The liver filters, about half of it out. So they only get half of the dose that we were wanting them to get. So chewing them, letting it absorb through the mucous membranes, letting it absorb all the way down the esophagus, they'll get much more of a dose. Nitroglycerin helps in STEMI, or it doesn't really help that much in STEMI. It helps in non-STEMI more than it does in STEMI, but we're going to use it exactly like we always have. Always remember your Viagra type drugs Viagra is up to 24. Your longer acting one's up to 48 hours. Um, it's pretty important. They're both vasodilators, one on top of the other. Nitro actually potentiates the Viagra mechanisms, and you get more than you want of the vasodilation, and you drop your blood pressure. And like I said before, the blood pressure um, is very important to keep the heart perfusing. IV access is a must. Multiple IVs is even better. Good 18 gauges, something like that. Um, if you do find out that your blood pressure is low, we can fluid bolus. We don't want to throw a ton of fluid at the heart, but if the patient's dehydrated or if they're hypovolemic for any other reason, um, we can give them fluid. Don't be afraid to give them fluid. Your protocol is going to stop you at a liter, but you're going to play that by ear. If they don't have blood pressure after a liter, then they need a pressor. While they only need a pressor if they're, if your fluid status is where it needs to be. So we don't really have to worry about that too much pre-hospital. There's enough time. So aspirin, 12 lead nitro. Do the 12 lead before the nitro. Sometimes, you do 12 lead, you'll see STEMI, and you're like, oh, all right, start treating that. You start treating it with aspirin and nitro, and all of a sudden the STEMI goes away. And you guys are getting good at doing serial EKGs. Perfect. Do as many as you can between the patient's house and the hospital. All you gotta do is push the button, so there's no excuse not to do serials. You can change your treatment can change the way the 12 lead looks, and if you end up at the hospital and they shoot a new 12 lead and it looks perfect, and you're like, well, but we'll do it STEMI before the treatment. That process gets kind of delayed, and then, well, maybe they're not having, they'll do their labs. And then, at the end of the day, we end up not getting to a cath lab. That's where they needed to be. Even though you resolved their STEMI, it's probably only temporary because nitro doesn't last that long. You might just open that artery just enough, and it's going to close back off. Okay, so nitroglycerin, we're giving 400 mics every couple minutes. You're stopping at 1200 mics. Your CHFers, they need nitro, and they need those 3 nitro as fast as you can give it to them. Plus, if they're hypertensive, if they're remaining hypertensive, use your nitro paste, 1 or 2 inches on the chest. And if they're having breathing problems, they have a decent blood pressure, use your CPAP for your CHF patients. Okay, so oxygen, remember what I said about that. It's not a concentration problem, it's a ventilation problem usually. Okay, and you can go through this and they have a little, your little flow here, kind of keep you on track here. So, key points, 12 lead EKG, nasal cannula oxygen, aspirin if indicated. Okay, and remember the contraindications to aspirin are any GI bleeding, any allergy. There's a couple weird things, Van Willenbon's and some crap like that, but don't worry about those. And you know what? And you give aspirin and you're like, oh, I have this, GI problem. Well, okay, the aspirin is going to maybe cause some problems to that, but you chalk up to a mistake, but it's a good one because it's actually going to help out their heart, and they can worry about that little GI bleed later. If you have known the cause, just don't do it. It's just a lot easier. But if you end up accidentally giving it to them, it's not the end of the world. So this is your chest pain, acute coronary syndrome protocol, and we're going to stop the video here and see how it went.